नमस्कार दोस्तों, welcome to channel Toxicology on board. Today in this video, in continuation with ICH S8 Guideline, we'll be discussing some of the other sections of the guideline. Okay, so we are discussing May 2026 published ICH S8 Guideline, that is Immunotoxicity Studies for Human Pharmaceuticals. So we'll go through section 2, which is given in the guideline. So what you have to read with respect to section 2 is that what are the factors to consider in evaluation of this potential immunotoxicity. So there are around 6 factors are there with respect to under this section 2.1. So factors to consider in the evaluation of this potential immunotoxicity. For example, you are a pharmacologist or you are a toxicologist. You are developing a new drug and you need to assess whether the new drug whichever I am developing, whether from in the battery of toxicology tests, whether I need to do immunotoxicology studies or not. How to come to that conclusion, whether a dedicated immunotoxicology study is needed for this developing new drug or not. So that question will always come to the pharmacologist or to the toxicologist. So you have to follow ICH S8 guideline. So in that, what you have to do, you have to check for these 6 factors. See, for any new molecule, whichever you are developing, no, it is not mandatory that every molecule you need to do immunotoxicology study. Before deciding whether to perform an immunotoxicology study, you need to check these 6 factors. If from these 6 factors, if you are able to derive that information and you are able to assess based on weight of evidence approach that there is no potential concern for immunotoxicity study following the 3R principle, then there is no need of conducting any dedicated immunotoxicology studies. So what are those 6 factors we'll see? Okay. So factors to consider that might prompt additional immunotoxicity studies can be identified in the following areas. So what are those we'll see? Findings from the STS. STS is the standard toxicity studies. So each and every sections like 2.1, 2.2, 2.3 up to 2.6 we'll discuss in the next 2 slides. Okay. Second one is the pharmacological properties of the drug. So what are those maybe PK properties or PD pharmacodynamic properties that we have to consider? Third one is the intended patient population. Here, gender, sex, age of the population, those things, genetic predisposition of the population is also considered. Next is the this 2.4 we will be going through structural similarity. So we'll discuss with one case example also to known immunomodulators. Okay. Then we have disposition of the drug, where the drug is going and getting deposited. Again, pharmacodynamics will come into picture, like whether the drug is going and getting deposited in high concentrations in the immune organs like thymus or thyroid or pair patches. Clinical information. If the drug is under investigational stage and you have done some phase one trials, or the phase one trial is still under conduct of trial, and in few patients, if you have found some immunotoxicity, then that should be a hallmark to understand that yes, we need additional immunotoxicity studies in the case of animals. If you are not done till now, okay. The initial screen for potential immunotoxicity involves standard toxicity studies, data from the rodent and non-rodent, here both rat, mice and non-rodent, that is rabbit, monkey or dog, from early short term means it may be 2 week or 4 week, or more chronic repeat dose toxicology studies, it means like 28-day or 3 month or 90-day study or 1 year study should be taken into consideration. Additional details on the parameters that should be evaluated, and the reporting of histopathological findings are provided in the appendix. So in this guideline, towards the end, last few pages will be there, no, appendix will be there. That also you have to read. That we will read in the next subsequent videos. So initial review of the standard toxicity studies to select the most appropriate species. So whenever you are doing some dose range finding studies, you will identify whether I have to selection of the species will be there, no. So that you will decide whether I have to do the studies, further studies in the mice or rat or rabbit or dog or monkey. Gender for immunotoxicity study, whether I have to go for male or female based on weight of evidence. Structural changes in the immune system. If there is if there is a trigger to the T helper cells or natural killer cells, and general toxicity, default female mouse cell. So once you do this weight of evidence, no, then you will go for whether I have to go for TDAR assay, that is the T cell dependent assay that we'll discuss in the next video. And if whatever the dose related positive effects are seen at less than maximum tolerated dose. Again, MTD is very important. I have I have made one video regarding MTD, where you have MTD as a point of departure at three different type of studies. One is a single dose toxicology study, one is repeat dose toxicology study, another is cancer carcinogenicity 2-year study. Okay, here we are discussing about repeat dose toxicology study, that is MTD, maximum tolerated dose. If you have seen the dose related positive immunotoxicity seen at less than maximum tolerated dose, then you have to consider that investigational molecule has a potential concern for causing immunotoxicity. Okay, so if there is a negative, you have performed TDAR assay or natural killer cells, whatever assay is there, then you found the results are negative. It is not triggering any NK cells. Okay, then you have to reconsider. Again, you have to go back to the step one, that is weight of evidence approach, okay, for potential immunotoxicity, because you have to confirm it. Some evidence of immunotoxicity potential, that is, you have to again, in addition to TDAR assay, we have what we are performing. We are performing NK cell activity assay, and if from this, the results from this NK cell activity, if you get positive at less than maximum tolerated dose, then it is again, we have to consider the final conclusion will be the investigation new drug is immunotoxic. If the results you will get it as negative, then you will consider that no further dedicated immunotoxicity studies are needed. It is non-immunotoxic. Okay, so this is the decision tree that you have to keep it in mind. If you are a pharmacologist or toxicologist, definitely the drug discovery team will definitely approach you asking for your opinion on this. Okay. So next section 2.1.1. So similarly, I don't know, all the six factors will be discussing in detail. So with respect to what you have to read with section 2.1.1 is what are the standard toxicity studies in the ICH S8 guideline. Okay. So like we have, when you're developing a conventional molecule, you have battery of toxicology studies too. So under, if I'm developing a new drug, what are the standard toxicology studies I need to, the results from this STS studies, how can they help me in deciding whether I have to go further for immunotoxicity study or not? Okay. So data from this STS should be evaluated for signs of immunotoxical potential. Signs that should be considered, taken into consideration are following. So what you have to see, hematological changes. If you have performed any blood parameters, in that you have to additionally you have to look for whether there is any leukocytopenia or leukocytosis. You have to read this term, penia and cytosis. Penia is decrease in the cell count, whereas the cytosis is increase in the cell count. So similarly, you have to look for granulocytopenia and granulocytosis, lymphopenia and lymphocytosis. Okay, pause the video and see what is the increase or decrease in this type of blood the hematological parameters. Next, you have to see alterations in the immune system, organs, weight, and histology. So we have immune organs like thymus is there, spleen. Is there organ weight changes is there? Is there any increase or decrease is there? And you have to also check for histology, changes in the thymus, spleen, lymph node, and bone marrow. Next, the changes in the serum globulins. A by G ratio will be there, albumin by globulin ratio that occurs without a plausible explanation. See, whenever you are conducting any study, if there is any change, there will be some explanation, some rationale why there is an increase or why there is a decrease. When you do not end up with any explanation, means it might be one of the concern might be a reason might be then immunotoxicity. Okay, like that you have to make weight of evidence, such as effects on the liver or kidney, can be an indication that there are changes in the serum immunoglobulins. So whatever these changes in serum globulin, if you are not able to explain it based on that other factors, so one of the concern might be immunotoxicity. Next, increased incidence of infections. If there is an immunosuppressive viral infections are there, some bacterial infections are there, because of which these parameters, immunoglobulins or these changes might occur. So those things also you have to look for whenever you're looking into this repeat dose toxicology data. You have to also look for in those animals any infections are there, bacterial infections or viral infections. Is it test item related is there, or is it suppressing, or the immune system is getting suppressed because of these drugs? As a result, there are these animals are more prone to infection. That also you have to check. Next, increased occurrence of tumors can be viewed as a sign of immunosuppression. So you are developing a new drug, investigational drug. If it is going to suppress your immune system, as a result, what happens? Your body will be in a compromised stage. As a result, you might get some additional tumors or secondary type of tumors, okay, for which there is no explanation. If those tumors, if you are able to explain the reason is because of either genotoxicity, either because of the DNA damage, or because of the hormonal changes, or because of the liver enzyme induction, then it is fine. It is nothing related to immunotoxicity. There are a formation of tumor in these repeat dose toxicology study animals, and those tumors, if you are not able to explain it based on gene tox, hormonal, or enzyme induction, then in that case, you can think that the reason might be immunosuppression. This drug is causing immunosuppression. As a result, in animals, you have found some kind of tumors. So these are the 6 things that you have to check in the standard. You are not doing any new studies. Already these studies are there, 28-day, 3-month, 90-day, or 1 year studies are there. From these repeat dose toxicology studies only, by looking into additional things like hematological parameters, globulin levels, or checking into histopathology, like this you can able to identify whether there is a potential concern for immunotoxicity. Okay, then we'll look into another section. What are the in continuation of the standard toxicity studies only? What are the things that you have to check? What are the standard toxicity studies in the ICH S8 guideline? Changes in these parameters. In the previous slide, we have seen the parameters could reflect immunosuppression. That is always throughout this video, this particular ICH S8 guideline, two things we are reading. The newly developed investigational drug might either cause immunosuppression or it might cause immunoenhancement, and that it should be unintended. Okay, that's why it is adverse effect. Okay, so immunosuppression or enhanced activation of the immune system. Immunosuppression is usually reflected by reduced values that we have seen leukocytopenia. Okay, of immune parameters, whereas immunoenhancement, that is cytosis, leukocytosis, granulocytosis, okay, lymphocytosis is usually reflected by increased values. Okay, you can go back in the previous slide and check that values. However, these relationships are not absolute and can be inverted in some cases. So always this is the thing that you have to understand as a scientist, as a scientific person. We tell one statement, but always there will be an exception to the particular statement. So even though there might be increase in the count or decrease in the count, there might be certain investigational drug where this particular statement might not be applicable. There will be always exceptional chemicals will be there. Okay, that you have to always keep it there. Nothing can be generalized. Few things can be generalized to some extent, but always there will be some or other exceptional statements will be there. Okay, that you have to remember as a scientist. Next, similar to the assessment of the risk with toxicity in other in organ systems like liver, kidney, heart. The assessment of immunotoxicity should include. So what are those need to be included? That we will see. Statistical and biological significance of the changes. Now we have discussed in the previous slide about leukocytopenia or the leukocytosis means granulocytopenia or granulocytosis. The change in numbers are there. Increase or decrease in number of cells is there. But it has to be statistical significant. Once you get the result, it should not be that only out of 6 animals which you have kept in a single group, only one animal or two animal it is showing. Statistical significance is important, and that whatever the information that you got, no, it has to have a biological relevance also, biological significance. That is how you write is that is how a study director writes a study report. Okay, so statistical and biological significance of the changes is important. Severity of the effects. There are certain changes which can be reversible once the treatment is stopped. So that is whether if there is a change in color or size which is not having any significance or it is not critical effect, such effects can be ignored. So severity of the effect, that is criticality of the effects, dose response relationship or exposure relationship, how the relationship between the effect and the dose is there. If there is an increase, that is granulocytopenia, leukocytosis, how things are observed at low dose, mid dose, and high dose and control, that you have to see. Okay, dose response relationship you have to check. Safety factor above the expected clinical dose. Treatment duration, whether it is 4 weeks or 2 months or 3 months, like that. Number of species and endpoints affected. As I told you, in a group, if you are taking 6 per sex per dose or 10 per sex per dose, how many animals are showing, how many are odd numbers, those things you have to check. Changes that may occur secondary to the other factors, like stress. So that you have, as I told you, towards the end of the guideline, appendix will be there. That you have to see section 1.4, possible cellular targets or mechanism of action. This is also very important. That's why STSP first factor what we had is pharmacological properties. So this is very important. What is the possible cellular target and mechanism of action? The same class of chemicals is there. How to understand that this new drug is also having a potential concern that of the existing generation drug. Okay, the doses which produce these effects changes in relation to doses which produce other toxicity or reversibility of the effects. Okay, if you have a reversible group, that is recovery group is there after the treatment, or the recovery group of animals are how they are showing, those things also you have to check. So pause the video and check all these parameters. So if there is a study director who has worked on immunotoxicity studies, he will be well understand about this particular section. Next, we'll see in continuation, I told you 2.1 we have discussed, that is pharmacological properties and the standard toxicity studies. Now we are going to discuss pharmacological properties. That is, what are the pharmacological properties and intended patient population. So 2.1.2 and 2.1.3 in the guideline we are discussing. Pharmacological properties are, if the pharmacological properties of a test compound indicate it has a potential to affect the immune function. For example, you are developing a new drug and that new drug is having anti-inflammatory drugs. Already you know that this drug is having anti-inflammatory properties. Okay, so the pharmacology properties of the test compound, whatever the new drug which you are developing, indicate it has a potential to affect the immune function. Then what you have to do in your battery of toxicology state, by default you have to include the immunotoxicity. Additional immunotoxic testing should be considered. Okay. Next, information obtained from the non-clinical pharmacological studies. So you do some efficacy studies you will be doing on the ability of the compound to affect the immune system. If it is going to tweak your T helper cells or natural killer cells, okay, could be used as a weight of evidence approach. So um, we have seen the previous slide. In next slide also we'll see weight of evidence approach will be there, where you have to integrate the results from various studies, okay, to decide if additional immunotoxicity studies are needed. Overall, the purpose, main objective of this guideline is whether we have to do any dedicated toxicology, that is immunotoxicity study or not, whenever you are developing a new drug, okay. But how we can minimize by using the existing toxicology studies, okay. So next is intended patient population. Here you have to see additional immunotoxicity studies should be warranted if the majority of the patient population for whom the drug is intended is immunocompromised. For example, in your trial, you are considering the patients who are kidney failure, you're considering patients who are liver failure, or you're considering a patient who is already having a cancer. Already in those section of the people, already their immune system is compromised, or they might be having certain genetic disease. Okay, so in such cases, or there might be concurrent therapy will be there where you are using comorbid conditions. So in this case also, you have to look for the intended patient population. So pause the video and check here the different immune system organs. And also I request you to remember this diagram. This is the normal range and this is the immunoenhancement. In the case of immunoenhancement, you have hypersensitivity. There are some autoimmune disease like that is multiple sclerosis. Some other reactions are there that you have to remember. And coming to immunosuppression, susceptibility disease. For example, in the case of what organ transplant also, intentionally if you are giving immunosuppressant drugs, that will not come under ICH S8 guideline. That you have to remember. We are developing a new drug, unintendedly it is has to either cause immunosuppression or immunoenhancement. Those class of drugs only can be considered as the ICH S8 guideline. Okay. Then next we will see under the six parameters only, some other sections we are discussing 2.4, 2.5, 2.6 we'll discuss what are the structural similarity, disposition of the drug and signs observed, and lastly collecting the information from all the six parameters, how we can apply weight of evidence. Okay, so for our final decision. So structural similarity, compounds structurally similar to compounds with known immunosuppressive properties should also be considered for additional immunotoxicity studies. So whenever you are developing a new drug, you have to also check for the structure of that particular investigational drug. If it is similar to that of the existing generation of the drug, so and that existing drug is already having immunosuppressant or immunoenhancement properties, so you can already assume that whatever the new drug you are developing, it might also have some immunotoxicity. Okay, you can add that particular parameter also to your battery of toxicology studies. Here I have taken one example like thalidomide. So thalidomide, all of us, we already know that this is the classic example of the drug where pregnant women have taken this drug and they found teratogenicity. But what exactly has happened in the case of thalidomide is that the drug which they developed is R-thalidomide. So we have under enantiomers, we have R-enantiomer and S-enantiomer. The drug which they developed in the European countries was R-thalidomide. Okay, R form. Okay, optical rotation is R form. So here, what is the main purpose why they have given into the pregnant women is pregnant women, they undergo nausea. Okay, they undergo vomiting. They have morning sickness. To overcome that, they prescribed this particular physician used to describe this R thalidomide. But what has happened when this pregnant woman taken this drug in our body, the R form was converted into S form, and this S form is the one which is causing you this teratogenicity. In addition to teratogenicity, this R form will also cause immunotoxicity, immunomodulation. Okay, so this is a classic example of how the structural similarity. See, both S-thalidomide and R-thalidomide are structurally same. Here you can very clearly see. But the optical rotation you see, the wedge, here the hydrogen group is there, no? It is converted into R form. Okay, here it will restrict you, the optical rotation will be there, no? That will be there. So this is an example. So whenever you're working on other pharmaceuticals, you look into what are the other examples. This example I remembered about thalidomide, that's why I have included here. You can go back and check. Okay. Next, we'll see the next section, that is disposition of the drug. So disposition of the drug is where the drug, once you administer the drug, where the drug is getting going and depositing. For example, there are certain drugs which go and deposit in your fat tissue. There are certain drugs which will go and deposit in your liver. They get start accumulating in certain organs. So in case of these drugs also, you have to check whether this drug is going and depositing in your thyroid gland, whether it is going and depositing in your bone marrow, or it is depositing in the thymus. So these are the immune function organs are there. No, if the drug gets deposited in this immune system organs, then there is definitely a potential concern for immunotoxicity. So we'll see if the compound or the metabolites are retained at higher concentrations in the cells of the immune system, additional immunotoxicity study should be considered. So this is another one red flag you have to remember. Last one we'll see trials. Since we are developing a new drug, you might be under phase 1 trial. So few patients you might be already, sorry, few healthy volunteers you might have already be conducting or ongoing clinical trial. In that clinical trial in the patients, if you see that there is an increase in TH cells or NK cells activity has been changed, or some essays you have performed where you can have, where if you find that there is a potential concern for immune system. There are clinical findings suggesting of immunotoxicity in patients exposed to the drug could call for additional non-clinical immunotoxicity studies. These are the 6 things. Once you get the information, these are the things that you can see in the existing repeat dose toxicology study. Then you have to perform weight of evidence approach. So what is this weight of evidence approach? We'll see under section 2.2. Weight of evidence review should be performed on information from all the factors outlined above to determine whether is a cause for concern. As I told you, if out of these 6, if there is any red flag is there, then you have to decide. A finding of sufficient magnitude in a single area should trigger additional immunotoxicity study. If there is a change in NK cell activity, if there is change in a granulocytopenia or leukocytopenia, neutrophil count, all those things you have to check. Findings from 2 or more factors, each one of which would not be sufficient on its own. Weight of evidence is the purpose is only out of 6 factors, 3 or 4 should show positive findings, it should show. Could trigger additional studies if additional immunotoxicities are not performed. If I am a scientist and I have decided that I will not conduct further, I have some red flags from the 6 parameters, but yet I am not proceeding with the additional immunotoxicity study, then I have to give rational, scientific rationally, I have to give it to the regulatory body, to the FDA or EMA or Canada. Okay, if there are red flags, you have to do. If you're still not performing anything, then you have to give justification to the FDA or like that regulatory agency. So these are the things that we have discussed under this particular guideline. These are the sections. So we have seen what are the factors that will be considered in the evaluation of this potential immunotoxicity. One is standard, that is repeat dose toxicology study. The results can be from 2-week tox study, pharmacological properties of the drug, whatever the investigational drug we are doing, that is mode of action, target organs, liver, kidney, PK and PD. Then intended patient population, we have seen what is the age of the population, whether it is pediatric or geriatric, or it is a children population, female population, gender, male or female, genetic background, there is any genetic disorder is there, comorbid, if the patient is having both hypertension and diabetes, and health status of the patient. Structural similarities of known modulators. Under this, we have discussed thalidomide example, cross reactivity risk with endogenous proteins. Since these are immune related, no, there are certain patients who are allergic to penicillins, certain patients who are allergic to certain type of like we have artiol, uh, like that certain chemical class of chemicals for which these set of populations are more um, having more cross reactivity to this particular agents and other biologics. Clinical trial information, safety data from ongoing or completed clinical trials. As I told you, it might be under phase 1, including immunogenicity and adverse events. So these are the risk factors that you have to see, 6 factors. And under parameters, I told you, under hematology, you have to look for leukocyte count. Under clinical chemistry, A by G, that is albumin by globulin ratio. Under histopathology, once you cut open the animal, look for the organ size, whether the thyroid size has increased, whether the thymus size has increased or decreased. Is there any color change is there? That things you have to see. Gross pathology and organ weight. Weigh the organs. Like you have to weigh thymus, you have to weigh the thyroid. These organs you have to weigh and check the organ weight changes are there. All lymphoid tissues should be evaluated for gross changes at necropsy. Then histology. Histology coming to all the immune related functions, organs will be, like thymus, spleen, lymph nodes. Okay. In the case of respiratory system, you have to look for BALT and NALT. In the case of stomach lining, you have to look for pear patches. Okay. So these things, is there any histological changes are there that you have to check under microscope? Okay. Then what are the factors that you need to consider for the immunotoxicity assessment? Pharmacological properties, non-clinical studies, that is efficacy studies, intended patient population, if there is any disease state or concurrent therapy, structural similarities, then disposition of the drug, then clinical information. So a weight of evidence review should be performed on information from all the factors outlined above to determine whether there is a cause for concern. Okay. So this is a decision tree that we were discussing about. So whenever you are developing a new drug, you have to check what are the factors that has to be considered in the weight of evidence, and does the weight of evidence warrant any additional immunotoxicity study? If it is yes, then you have to consider TDR assay or NK cell assay. Okay. And if there is no further assay or no potential concern is there, no further non-clinical testing is required. Okay. So these are the weight of evidence that you have to consider. A finding of sufficient magnitude from a single factor that we have seen in the guideline only, and findings from 2 or more factors, each one of which would not be sufficient on its own. Additional immunotoxicity study should be completed before exposure of large population of patients. Before initiation phase 3 trial, you have to complete this immunotoxicity study. That's why we're discussing whatever the information that you get in clinical trials, no, it has to be from the phase 1 or phase 2 only. Okay. If additional immunotoxicity studies are not performed, the sponsor should has to give justification to the regulatory bodies, either to the FDA or EMA. I would request you to pause and look into this specific immunity, because since we are reading about immunotoxicity, you have to read about what are the innate immunity, what is the adaptive immunity. This is a specific immunity where clonal expansion is there. You have cell-mediated immunity as well as humoral immunity, where interleukins and IFN alpha are involved. Okay. Also, pause the video and read about these examples. So in the exam, you will get some examples. From the examples, they will ask you questions like, these are the list of the chemicals or drugs or metals where they are going to inhibit the immune function. For example, Agent Orange, which comes under the class of polyaromatic hydrocarbons. Metals like lead, cadmium, and arsenic, they are going to inhibit the immune function. Then we have organic solvents like benzene and toluene. Okay. Then we have oxidant gas like ozone, sulfur dioxide, and nitric oxide. And we have particulates like asbestos, silica, and beryllium. If you look into this ozone, even UVB is also involved, which is also going to trigger, which is going to inhibit your immune function. Some mycotoxins like T2 and acrotoxin, and drug of abuse like marijuana, alcohol. So if you look into this list, no, already n number of questions have already been asked on these class of chemicals in the previous ABT exam. Okay, so some questions on mycotoxins they have asked, some questions on ethanol they have asked, some questions on that is photochemical smog and London smog they have asked, some questions on organotoic, that is triethyl tin also they have asked, some questions on benzene and toluene, metals as well as Agent Orange. So these are the frequent areas where the ABT questionnaire will keep asking you the questions. Okay. In addition, I would request you to pause the video and look into stem cells. Once we have the stem cells, no, since we are discussing on the topic of immunotoxicity, once you understand these particular lineage only, it will be easy for you to further understand TDR assay or NK cell assay, because these are the two assays that are mentioned under the guideline, ICH S8 guideline. So once the stem cells are there, no, they differentiate into lymphoid stem cells and myeloid progenitor cells. Okay, these lymphoid stem cells will further differentiate into T cell or T helper cells. So whatever the TDR assay is there, no, that is with respect to T helper, that is Th1 cells and Th2 cells, and we have cytotoxic cells. Coming to B progenitor cells, we have memory cells, plasma cells, and natural killer cells. So one essay with respect to NK cells will be there. Pause the video and read it. And coming to memory cells, so here a response is to the secondary exposure to the antigen. First exposure, the person is fine, but upon second exposure, based on these memory cells will identify that particular allergen and it will cause a reaction. It might certain times end up with anaphylactic reactions like STN, that is or what is that is anaphylactic reactions like Stevens-Johnson syndrome or TEN, that is toxic epidermal necrolysis. Those things can happen. Okay. Coming to myeloid progenitor cells, read about neutrophils, eosinophils, basophil, and mast cells and monocytes, which further differentiate into dendritic cells and macrophages. In this one questions, one of the area might be they'll keep on asking you about which of the following are phagocytic cells, which are the non-phagocytic cells. Like that, some questions will come. Okay, then uh, as I told you, since we are discussing about the immune system, so whatever the response is there, is it the rapid response that is non-specific? I am a certain individual. If I'm exposed to certain bacteria or certain virus, okay, so there will be immediate response. Irrespective of whether I know that bacteria, my body will react. Immediate reaction will be there. No, that is non-specific. Okay, that is rapid response, innate immunity. Okay, coming to adaptive immunity, where secondary exposure or clonal expansion is needed. Okay, that is specific response, develops over a time. Okay, antigen specific response. For example, I am allergic to certain pollen grain or certain chemical. So in that case, no, my body will recognize and it will create a memory cells, T helper cells. Whenever the second time of exposure will be there, so antigen specific response will be there. This is something called delayed type or adaptive immunity. Involves B lymphocytes and T lymphocytes. That's why you need to go back and remember that lineage. And clonal expansion and differentiation. Previously, we have seen this clonal expansion, no, provides long-term lasting protection and memory. Okay. So pause the video and read about these two types, innate immunity and adaptive immunity. Also that cell-mediated immunity and humoral immunity also you try to remember and try to remember the different type of cells, because further next essays, to understand the essays you have to understand what is this natural killer cells as well as this TDR assay, that is T helper cells, humoral cells, that is Th1 and Th2 cells. Okay. Hope from this video you were able to learn about this different types of toxicology studies. The main agenda objective of this guideline is before going for a dedicated immunotoxicology studies, by using the existing information from the repeat dose toxicology studies, by following those six factors. See, whatever these ICH guidelines are there, no, they are in alignment with 3R principle. They do not want to conduct additional animal studies. So from the existing animal toxicology studies, from that information, if you are able to come to a conclusion by following this weight of evidence approach, uh, then we can minimize a dedicated study that will imply the 3R principle. Okay. So next videos we'll discuss about TDR essay and NKSL essay. Thank you so much. Be curious. All the best for your exam.